right. Thank you again, everyone. I hope you enjoyed your lunch, and I will do my best to be enthusiastic and keep us all awake after eating. So I'm going to be talking today about some of the work that I have been doing alongside other colleagues at MUSC to try and understand more about how we can help people quit using their e-cigarettes. And so, again, we have seen these data before today, so I'll just kind of quickly go over them. But I do want to, point out that cigarette smoking is at an all-time low since the 1960s, and that's largely due to the great work of the people here in this room. And I think, importantly, what we need to recognize is that you all have set the stage where people are very well informed about the health impacts of their smoking. Smoking is not necessarily acceptable. It's not an easy thing to do anymore. And so when we see people transitioning to other products, it's because of the work that you've done to make people more aware of what's going on with smoking. And so, again, really great progress has been made in that area. Again, South Carolina, as we know, has a little bit more work to do, but we're doing great work here. And at the same time, we are seeing things like e-cigarettes pop up and become more popular. And similar to our prior presentation, it's important to know that in youth and young adults, again, e-cigarette use is becoming the most popular tobacco product used. So the graph that I'm showing here is 18 to 24-year-olds. These data are a little bit old. They're from 2021. But what it shows, so first to back up, this is a very important age group because these are the young adults that sort of predict what might be going on in the future. If we look at young adults' buying patterns and their social patterns, those tend to carry on throughout their lifetimes and future generations. So tobacco companies know this, and they actually use this to predict what tobacco trends might look like in the future. And so what we're seeing here is cigarette use has extremely dropped among this group. Cigarette smoking's maybe a little bit over 5%, but e-cigarette use is up to about 15%, again, as of 2021, and half of those people have never smoked a cigarette before. So from a health perspective, definitely a step in the right direction, but now we've got, again, all of these people who have had no exposure to cigarette smoking and tobacco use that are using e-cigarettes and maybe having some negative consequences. Another important thing that can happen with e-cigarette use is it may lead to a pattern called dual use. So some people may be smoking cigarettes and they start using e-cigarettes because they want to quit smoking, which is great. And for some people, they're successful. And again, that's a great step in the right direction. For other people, what happens is they end up smoking and vaping. Maybe they're doing it to try and quit smoking, or maybe they're just experimenting with e-cigarettes. Some people use e-cigarettes in spaces where they're not allowed to smoke, and then they'll smoke when they're at home, things like that. And so, we think about 40% of people who are using e-cigarettes are also smoking at least once a week. And an important thing to consider there is that means you're getting nicotine from two different sources. So there's multiple opportunities for you to get nicotine, and that can maintain that addiction there. Again, nicotine is an addictive substance. The other thing, too, is that, again, some of these people who end up in this dual use pattern may smoke fewer cigarettes than they did before, which again is a step in the right direction. Some people's smoking doesn't necessarily change, but either way, they're getting exposed to tobacco smoke. And everyone in here is very well aware of the harms for continued smoking. And so again, people that get stuck in this dual use pattern, they're a very important population that we want to understand and help. So one of the issues that we've run into as clinicians and researchers is that e-cigarettes that are available out there in the marketplace are moving very, very quickly, as we've seen, and our research moves very, very slowly. And so, again, we know that most people who vape and most people who are in this dual use pattern want to quit. But we don't have a lot of evidence-based treatments out there, meaning we can make guesses about what might help people quit vaping, but there hasn't been a lot of science to test if this is actually going to be useful. And it's really important to have that because we don't want to be giving people treatments that don't work very well. We don't want to be giving people the wrong kind of treatment. We want to make sure our treatments are actually helpful and not detrimental. And so we do want science behind these treatments that we're doing. Most people who try to quit vaping or try to quit dual use do it cold turkey, so kind of unassisted, and they're not successful. Again, consider that some people have really high nicotine dependence, especially if they're using multiple products. And so some of the treatments that we might use for smoking cessation could potentially be applied to this people that are vaping and dual using because we're treating nicotine dependence. So things like nicotine replacement therapy and varenicline might be promising, but our best practice is, of course, to combine behavioral support with a pharmacotherapy. We know that that's, leads to our best outcomes in tobacco treatment and with other psychological conditions. Oftentimes, a medication plus some behavioral support is going to have our best outcomes. So the first study that I'm going to talk about is a study that I did looking at nicotine replacement therapy for e-cigarette cessation. So this was, the study was published in Addictive Behaviors. Again, if any of you are interested in some of the research that I present, I'm happy to send you the articles because I know that they're not always easy to find or access. But basically, just to review for anyone who's maybe not as familiar, nicotine replacement therapy includes things like patches, lozenges, and nicotine gum. And they come in different dosages, which will be important for later. But essentially, when we've got someone who's smoking a pack of cigarettes a day, we usually recommend a 21 milligram patch and then 4 milligram lozenges, anywhere from 5 to 20 a day. So, if you're having a craving for a cigarette, pop in a lozenge. If you're smoking 20 cigarettes a day, so that's kind of where that comes from there. So nicotine replacement therapy is, of course, an FDA-approved over-the-counter medication for smoking cessation. It is not, however, for e-cigarette cessation. Even though we're treating the same chemical, the box is very specific that this is for cigarettes, and we can't formally and officially say that this is something for e-cigarettes. And so again, we need more research to learn more about how this might help people that are interested in quitting their e-cigarette use. So this is a study that I did when I was a postdoctoral fellow, so that means I was just a little baby scientist. So it was a small budget that was generously provided by my mentors. So I recruited 30 people for this study that wanted to quit their tobacco use. Half the people were just using e-cigarettes, and half the people were smoking and using e-cigarettes. And I wanted to see if the standard dose of nicotine replacement therapy that we would give a pack a day smoker would help people change their tobacco use behaviors. And so I tested the nicotine replacement therapy against our the tobacco quit line, which, as we have heard a lot about, has a really comprehensive vaping cessation behavioral support program built into it. And so what I found were some pretty interesting results. So these are the results for the people that were just using e-cigarettes. So at the end of 4 weeks of nicotine replacement therapy, about 40% of people had quit vaping, and that seemed to last about a month later. Again, some people who did not receive the medications ended up eventually quit vaping, but these were pretty promising results, again, although a very small sample. However, when you look at people who were using cigarettes and e-cigarettes, unfortunately, there was no change. A couple people had stopped using their e-cigarettes or their cigarettes for a little bit, but then went back to that dual use pattern. And so that was especially concerning to see there that there was really no movement in these people who are at greatest health risk. So what we learned from this, and the next steps that I would want to take are, a few things. One is, again, those concerning results about dual use were something I wanted to look into further, and we're going to be talking more about that in just a little bit. But the other thing was that, again, we found some good results with pharmacotherapy, but we know that behavioral support in pharmacotherapy is going to lead to the best outcomes. And so for some of the future work that I do, I want to be looking into these combined interventions. I'm a clinical psychologist by training, and so I want to figure out what are some of the best behavioral strategies to help people quit vaping. We know that counseling can be really effective, especially if it's intensive counseling, but that's not always easy to access. It may not be, covered by people's insurance. They may not be able to afford it. It might be really time-consuming to go to appointments like that or to do telehealth. That's on the billing side of things as a provider. That's a whole other can of worms. And so I want to look at different types of behavioral support that might be available. So things like social support text messaging programs, web-based programs, there's some vaping cessation apps that are out there, and different ways of increasing people's confidence and motivation in quitting. So I'm currently, as of right now, working on a grant proposal where I'm going to be looking at all of these different components and trying to see, what combination of these things is going to be best to help people quit vaping. And doing that in a framework in a way where I don't want this to just be a study that is published and put out there and then takes 20 years to get into practice like it has taken for smoking cessation. So I'm designing it by looking at both patient and provider perspectives in mind, with the goal that once I'm done with this study, the intervention will be ready to go and passed along to our providers, and it's something that they feel comfortable giving out, and it's something that our target population feels like is a good fit for them and their lifestyle. So that is one study I'm working on now. So going back to the results that I found where dual use, the people that were engaging in dual use did not have good cessation outcomes from that pilot study. That got me interested in trying to find out more about how to help that specific population. So the results of this study were actually just published yesterday, so that is pretty exciting. And this was a study that was funded by a grant that I received from the American Cancer Society through the Hollings Cancer Center. So when we're working with people who have high nicotine dependence because they're smoking a lot of cigarettes, right? People that are smoking 2-3 packs a day, we might recommend that they use more nicotine replacement therapy. One patch might not be enough. We'll recommend that people use 2 patches, or we recommend that they use more lozenges. Again, this goes against what's said on the box. It goes against what's the FDA-approved way of prescribing these medications. But there's a lot of data over many, many years that shows that this is a really safe approach and it's a really effective approach for people who are heavy smoking. And so I wanted to see if this same principle would apply for people who are engaging in dual use of cigarettes and e-cigarettes. So again, this was another smaller study, but what I did is I recruited 46 people who were using cigarettes and e-cigarettes that wanted to quit. And everyone in this study was offered 1 of 3 doses of nicotine replacement therapy. They either got what I'm calling the standard dose, which is that 21 milligram patch and about 5 to 20 lozenges. In the middle dose, they got a 21 plus a 14 milligram patch and were given up to 30 lozenges a day. And in our high nicotine replacement therapy group, they got 2 21 milligram patches and were given enough to have up to 40 lozenges per day. And so these are the results from this study. And so what you're looking at here is the results from 1 month and 2 months following treatment. And on the y-axis there is the number of people who were able to quit, again, both cigarettes and e-cigarettes, so quitting both products. So you'll see that the mid and the higher doses worked better than the standard dose, and they were actually pretty equal in terms of their outcomes. So the good news there is that higher doses seem to help, and that a middle dose might be just as effective as a higher dose. And that middle dose is good because that might reduce the chances for people for having side effects from getting too much nicotine from the extra medications. And so I currently have a grant proposal that's under review in just a few weeks, so send out good vibes that one gets some good reviews and goes through. But we're going to be doing a fully powered trial to see if high-dose nicotine replacement therapy can help people quit both smoking and vaping. So they're going to be randomized into 1 of 3 groups. One group will just receive behavioral support. One group is going to receive a standard dose plus behavioral support. And then the third group will be receiving that high-dose nicotine replacement therapy and behavioral support. We're going to be looking at cessation outcomes, including quitting both products, and also people that maybe just quit smoking and transition to e-cigarettes only, because that was a common outcome from that prior study. And then we're also going to be looking at changes in health outcomes. So I'm collaborating with a genetic biologist who's going to be taking some DNA samples and seeing if people's DNA damage improves over time when they quit. And so again, the goal here would be to help inform the FDA and our clinical practice guidelines for treating dual use of cigarettes and e-cigarettes. So making sure that providers feel comfortable and confident in the safety of giving out higher doses of nicotine replacement therapy to help these people. So the third study that I will talk about is a trial of varenicline for e-cigarette cessation. So varenicline, again, is a medication that I told you a little bit about in our prior presentation, so you should be familiar. Again, this was published recently, and it was done in collaboration with some colleagues that we have at the Yale School of Medicine. So it was actually a multi-site trial. We recruited people here in South Carolina, and we recruited people in Connecticut. So two different regulatory environments in terms of what's available for e-cigarettes, and two different cultures surrounding cigarette smoking. So again, just as a refresher for how varenicline works, it blocks and binds to nicotine receptors, so helps reduce nicotine withdrawal, and it helps make nicotine feel less rewarding. And so in this study, again, it was a smaller study just to see if we could, actually carry this out and maybe detect a smaller signal. We recruited 40 people who were using e-cigarettes and wanted to quit. And they received either a full treatment course of varenicline or they received a placebo that looked really similar. And so we've got our results here for 8 and 12 weeks following the treatment course here. And you'll see that varenicline had better abstinence outcomes than the placebo medication. And so we were able to take these results and applied for and actually received a grant from the National Cancer Institute to, again, do a fully powered trial of this study. We want to get enough people and capture, some more safety data to see if varenicline might be a good treatment option for people who are trying to quit e-cigarettes. So it's going to be a really similar setup. People will receive either placebo or varenicline alongside just a basic behavioral support. We're going to be looking at cessation and health outcomes like DNA damage and inflammation. This is a study that we're currently in the process of getting set up, and we should be starting to recruit soon. We'll be recruiting from across the state of South Carolina, and it's a remote study, meaning that we're going to mail everything to people. So they don't have to come all the way down to Charleston and try and find parking to be in the study. They'll be able to just have everything done through telehealth. So it's a really great resource, and again, I am happy to, when that's up and running, if anyone's interested, send the information out so people can refer others to that. The last study I will talk about is hoping to understand more about the health impacts of quitting e-cigarettes. So we know that e-cigarettes are less harmful than smoking, but they're not perfect and they're not without risk. E-cigarettes do have some health impact. We also know that, of course, quitting smoking is one of the best things that you can do for your health, but we don't know as much about what happens if you quit vaping. Can you also reduce the harms, or can you start to repair some of the harms that have been done by vaping if you quit? And so this is a small pilot study that was funded by Hollings Cancer Center that we're doing to try and find out more about the health impacts of quitting vaping. And the goal of this is maybe not to necessarily understand the long-term health impacts. There's not enough funding to do that yet, but just to get a small sense of what signals might we see, and what are we capable of really looking at. So we wanted to see different health impacts of quitting vaping. So respiratory, cardiovascular, looking at inflammation and immunity, and DNA damage. So this study is currently ongoing, and so very exciting. You are some of the first people who are going to see these data. So this is really exciting stuff here. So this looks very complicated. I'm going to walk you through it, but basically we are recruiting 30 people for this study. We're looking at people, so everyone uses e-cigarettes. We're looking at some people who just use e-cigarettes and have never smoked, some people who use e-cigarettes and used to smoke in the past, and some people that are engaging in dual use of both cigarettes and e-cigarettes. And so what people do is they're going to come in for what we're calling an in-lab baseline session, and we actually are going to have them vape or smoke, their products. And then afterwards, they get a bunch of poking and prodding done. So we do a cheek swab to take a sample of DNA. And here we're looking at DNA damage. All right, again, I'm a psychologist, so my understanding of this is, DNA damage is something that happens to us on a daily basis. If you go out in the sun, there's DNA damage. When you eat your lunch, there's DNA damage. This is different than a DNA mutation, which might lead to something like your cells acting funny and then turning into a tumor and cancer. But DNA damage is something that can be repaired. The problem is when your DNA is damaged over time, for example, through exposure to cigarettes over and over and over again, that can lead to a higher risk of having those mutations, which can then turn into a cancer. So this is sort of a proxy for looking at the potential for cancer risk here. We then have people do a nose swab, which I know always makes everyone cringe when they hear about, but this is better than the alternative. So the nose swab is a nasal epithelial lining fluid sample. And what that can do is actually take a look into what's going on inside your lungs without doing a bronchoscopy, which is a big procedure where we go inside your lungs and do a bunch of poking and prodding, and that's worse than a nasal swab, probably for most people. Although I don't like the brain tickles either. But it's a newer procedure that we're working with someone at the University of North Carolina to do, and that can measure different immune system and inflammation markers that are going on directly in the lungs just through doing a nasal swab. We're also having people do pulmonary function tests. So these are breathing tests to see your lung capacity, how much air can you hold in, how strong can you blow out, things like that. And then finally, we're doing a blood draw, and that is going to be looking at different cardiovascular outcomes and also things like inflammation. So they're gonna come in, vape and smoke, get poked and prodded for a little bit. Some people are going to get some nicotine lozenges, but that's irrelevant to what we're doing here. And we're taking a few samples of everything during that day. We then ask people to come in for the next week, and they are asked not to vape and not to smoke and not to use cannabis also for that full week. And they're paid pretty well to not do that. We do test them every day. I mean, we had to motivate people. They get tested every day, and again, they also receive substantial payments for not vaping and not smoking. And when they come in, we keep repeating some of these measures. So we keep taking DNA samples and nasal samples. On the last day, we redo those respiratory and those blood markers. So we're basically getting a sense about what happens in the body in a week's time when you go without vaping. And so I'm going to share two results where we actually saw some movement, which makes sense that we might not see it with everything. The first is going to be with our nasal swab inflammation and immune markers. So these are, again, just within our first 10 participants, and these are all people who were not smoking. The different types of immune markers are what's on the bottom x-axis. Again, I'm a psychologist, I don't know what these are, but they're different markers of your immune functioning, and that would be happening within your lungs. And you'll see that they're also labeled D1 or D7, so that's day 1, day 7. And long story short, you can see within these colors there are reductions in those markers just when going a week without vaping. So if you stop vaping for a week, the inflammation in your lungs tends to reduce, is what we're seeing here from just, again, a very, very baby small sample. In terms of the DNA damage, all right, so looking over onto the left, what you're seeing is the amount of damage that occurs. So basically what looks like it happens is, when you vape, shortly afterwards for a few days, your DNA damage rises, and then as you go without vaping, it tends to fall back. For the left, for the DNA intensity, we're sort of seeing the opposite. So that, I think, is the amount of repaired DNA that you have. So it tends to dip after you've vaped, and that dip continues for a few days. And then if you continue not vaping, that recovers. So long story short, again, vaping doesn't do some DNA damage, and you are able to start recovering it the longer that you go without vaping. So that's kind of the take-home message there. So the next steps for this type of work, we wanted to, again, see what we were capable of doing and see what we might find a signal for. And so, in this line of work, we can take these data and add it to some other studies that we're doing. So if we wanted to do an e-cigarette cessation study, we can look at also the changes in these health outcomes going forward, and look at changes in the specific markers so that we can have some information to tell people about how your body changes when you quit vaping. And that will be helpful, I think, for both researchers and for clinicians to talk about the benefits of quitting vaping. The other thing that we can do is also potentially compare what happens to people when they quit smoking versus when they quit e-cigarettes, or looking at people who transition from smoking to just e-cigarettes or transition from dual use to just using one thing. So this will help give us a sense about, again, when we're thinking about a risk continuum, how harmful is smoking compared to how harmful is vaping, it'll give us a little bit more information there. And so finally, I know I talked about this just a little bit later, but if you want to know more about quit vaping strategies and also just tobacco treatment in general, you've all got a flyer for our tobacco treatment specialist training that we do. Again, it's a really nice comprehensive training where you will learn the behavioral strategies for helping people quit smoking. You'll learn the pharmacotherapies, you'll learn, the different, policies and health systems and the history behind all of those. I want to just, put in a plug for our program specifically. We really try to emphasize talking about not just cigarettes, which some of the other training programs do, but we incorporate information about quitting e-cigarettes, quitting pouches. We talk about cannabis and alcohol in this. And so we try and really make it, comprehensive in that sense to stay up to date with what's happening in terms of the product use that people are doing. The other big focus that we have is on health equity and making sure that some of our populations that have been disproportionately affected by the health outcomes from tobacco use receive, care that is tailored and specific to them. So all of our presentations, really have a focus on making sure we're addressing things for specific groups as needed. Again, if the cost is prohibitive, you can contact Stephanie, who's on your flyer, and see if she can work with you. We have some options for discounted rates, and MUSC has discounted lodging options as well. So that's something we can definitely help you with. And finally, I just want to say thank you to all of the people who have helped me on this work. And again, thank you all for having me here. And I am happy to talk some more and take questions.
Questions?
Of course. Amanda, great job.
Yeah.
One of the things I didn't see you talk about, but I'm sure you've looked at, is nicotine fading, which would be with vaping, going from higher liquid, e-liquid concentrations for nicotine down to lower concentrations.
Yeah.
And are there studies that have looked at that? Because I, hear anecdotally a lot of people talk about doing that as a quit method.
Yeah, for sure. So there have been some, again, smaller studies of nicotine tapering to quit vaping. It's a strategy that's definitely highly acceptable, and for a lot of people that does seem to work. I am a co-investigator on a study with Natalie Walker in New Zealand where we're helping people quit vaping, and we're actually doing tapering versus nicotine replacement therapy. And then in the grant application that I'm currently working on right now, one of the components that I'm adding is to randomize people to either pick an abrupt quit date or to taper down to quit. So there's ongoing work in that area, but I definitely think that, one, it's highly acceptable to people who vape, but two, it can also increase confidence. For some people, and for those of you who have ever worked with people that are trying to quit smoking, when you suggest to them, let's pick a day to quit, sometimes it's very deer in the headlights, and that sounds like a too big of a step, and cutting back feels better for them, and it helps them feel confident. And so the question is that the same case with e-cigarettes, and how do we do that?
Great talk, Dr. Palmer. Quick question about how do we go from, and I'm curious because I'm not trialist, so I don't know, for instance, for the high dose study or even for the vernacular for e-cig, like how do we go from those trials that you're doing to actually being able to do those things in clinical practice? What needs to happen? Is it like FDA approvals, clinical guide? Yeah. What? Yeah.
Yeah,
Any-
that's the question. I think the first step would be to, disseminate the results to the FDA and to people who make those clinical practice guidelines and start those conversations and sort of see what some of the concerns are. I think changing the instructions on the box of NRT might be a really big lift. I don't know what would be involved in that, but I do know that the groups that come together to make the clinical practice guidelines will take into consideration some of these, studies that have come together. And, it says, in our standard clinical practice guidelines for smoking cessation, it says in there, although, it's not FDA approved to do so, you can use higher doses of nicotine replacement therapy for smoking cessation for people who are heavy smoking. So something like that, I think, would be an achievable goal, hopefully within the next few years of this research coming out.
Thank you.
Any other questions?
On your study that you're recruiting for, how can we be of help in that? I represent a county coalition. Can you speak to that?
Yeah, so I think any of the studies that we're recruiting for, one of the things that I like to do is try and use some of these community partnerships to share information, especially if it's a study that's available to everyone in the state. We have some research that's going on where we need people to be in Charleston, which I know is, again, that can be a difficult trip for people. But otherwise, yeah, I'm happy to, disseminate through Smoke Free South Carolina. And again, I work with Smoke Free Lowcountry as well. And, we try and sort of disseminate some of the research that we're doing out into those community partnerships for sure, as just, an additional resource for people.
All right. So I was just going to ask my advisors later, but I might as well ask while I'm here. So my question I wrote down was, if e-cigarettes require high doses of nicotine replacement therapy to quit, does that suggest that they can potentially be more harmful than traditional cigarettes? Or in your professional opinion, what do you think about that?
Yeah, so I think if e-cigarettes are requiring people to use more nicotine replacement therapy to quit, that might mean that people are getting more nicotine from their e-cigarettes than maybe some people are getting from cigarettes. I think, everyone's a little bit different, but some of the e-cigarettes have very high nicotine concentrations, and you can use them in different ways, right? When you smoke, it's sort of like 20 times a day, you got to go outside and, you have your cigarette for 10 minutes and then you come back. Whereas e-cigarettes, you can take a little bit every day. And from some people that I've worked with, they feel like they're getting more nicotine because they're just sort of mindlessly hitting it all day. And so those are people that are maybe getting more nicotine exposure. Nicotine by itself is probably the safest thing that's in cigarettes. It's, again, the addictive chemical. So the health outcomes that can come from that they're not as big as some of the things that might come from combustible tobacco, where the health harm comes from lighting it on fire and inhaling it. But there are issues that can pop up with too much nicotine that some people have. We've had people come in that want to quit vaping because they're getting jittery and they're getting headaches and they're getting anxiety. So things that, too much of any stimulant might give you. But there's also psychosocial impacts. So again, there's big mental health concerns if you're getting too much nicotine. There's cost, there's your time. Some people don't like feeling chained to it. So I'm thinking, again, if people need higher doses of nicotine replacement therapy for quitting vaping, that might mean that they're getting a lot of nicotine from their e-cigarettes, which is probably driving some of those problems that makes them want to quit.
Okay, thank you.
Yeah.
So leading on to what you just said, would you say less of the amount of nicotine that they're getting from vaping, that vaping just in general is more addictive than traditional cigarettes? Because you touched on how with your smoking you have to go outside and you don't want to do that, and then mindlessly just puffing. So of course they're getting more nicotine because they're constantly vaping. So would you say it's more addictive?
I think for some people, it definitely feels like it, yeah. Cigarettes are designed to be the best way to get nicotine. So what makes something addictive is how fast does that chemical get to your brain. In cigarettes, it goes really fast. And with some e-cigarettes, it goes probably just as fast. And so I think e-cigarettes, you know, depending on how you want to define addiction, right? That I think some people definitely do feel more addicted because it is easier to use them more often than they are with cigarettes. They operate a little bit differently, so some people maybe that's not the case. Again, we're seeing pretty good quit rates from some of these studies for helping people quit e-cigarettes. And so that might mean that maybe they feel more addictive, but they're easier to quit than smoking. So that's something else to sort of think about. But it might also just be sort of the impacts of the cultural norms of not using any nicotine or tobacco products that's driving people to then want to quit vaping and have an easier time with it. So that's definitely, as you know, research psychologists, that's one of the questions that we're trying to figure out. So it's good.
Thank you so much, Dr. Palmer.